So, hello everyone. My name is Rafiq Kandi. Today we will be discussing about the sleep disorders and the updates and changes in the ICSD-3 TR new guidelines. So, the objective of this talk is basically to examine the key sleep disorders and their diagnostic criteria based on the new guidelines, and then review significant updates and changes in the ICSD-3 TR, the text revision, which is published in June 2023. Analyze the clinical implications of sleep disorder classifications during polysomnography. So before further going into the topic, let's have a pulse check. If possible, can you scan the QR code and participate in this survey? I'll give you a few minutes for you to scan this QR code and give your name. You can give any name just to know, just to test the basic understanding of this topic. Can anybody scan? So how confident and familiar are you with ICSD classification for sleep disorders? This is the first question. All right, 2 people joined. Yeah. Let's wait for a few more minutes. So somewhat confident and familiar, very confident. So some people are saying not that confident at all. Okay. Next question. We know the G47.33 is a diagnostic code used for the obstructive sleep apnea. Which classification system utilizes this code? Is it International Classification of Sleep Disorders, International Classification of Diseases, or a Diagnostic and Statistical Manual for Mental Disorders, or none of the above? Yes. Let me give you a few more minutes. There is no right or wrong answer, just you can, no worries, you can just join. Okay, so it is saying 67% is saying it is an international classification of sleep disorders, and 25 is saying ICD, International Classification of Diseases, and which is the correct answer. Now, I will show you a video, just view it, and then there will be a question based on that. You can look at the sleep video. I'm not sure whether you are able to hear the audio, but there is audio going on. All right, the question is, what type of abnormality was observed in the shown video? Is it a seizure, REM behavior disorder, or sleep talking, periodic limb movement disorders? So RBD is the right answer. So 40% almost saying that it's a sleep talking or a periodic limb movement disorders. All right, so there are several classification and definitions of the sleep disorders. Initially, DSM-4, the Diagnostic and Statistical Manual for Mental Disorders, have classified sleep disorders basically from a psychiatric and a psychologist point of view, and it is most commonly used by them. And then there is something called as the International Classification of Diseases. ICD-10 is the version which we are using right now. This is mainly for giving management of the diseases in terms of coding and reimbursement purposes. So G47.33, the one which we discussed earlier, is basically an ICD coding. And ICD do have the coding and the management system for entire diseases affecting the humans, not alone the sleep alone. And then we have for the sleep alone, we have the International Classification of Sleep Disorders managed by the American Association of Sleep Medicines. So when we are looking at the history of the ICSD, International Classification of Sleep Disorders, we can see that it started from something somewhere in 1979. And then they have published the first ICSD classifications from 1990. In 2005, the second version was published, and in 2014, this is the recently used classifications, ICSD-3. And last June 2023, we had a text revision of the ICSD-3 TR, which was published. And this is the whole point of this talk is basically to discuss the sleep disorders and to discuss what are the new updates and changes with this ICSD-3 TR. So in the ICSD, there are 7 main group of sleep disorders. The first one is the insomnia. Second one is sleep-related breathing disorders. Third is central disorders of hypersomnolence. Then circadian rhythm sleep-wake disorders. 5, parasomnias, sleep-related movement disorders. And the last one is the other sleep disorders. If you look at the ICSD-3, the old one, they used to have an Appendix A and Appendix B. The Appendix B is no longer available in the ICSD-3 TR. So what changes have been made is that there is an addition of some of the diseases, there is modification of some of the verbiage writings, and then there is a deletion of some of the aspects of the ICSD-3. So first, let's go into the first disorder, which is this insomnia disorders. It has been classified into, we know that insomnia is difficulty to initiate or to maintain the sleep. And it has been classified into several: chronic insomnia, short-term insomnia, other insomnia disorders. So the chronic insomnia is how it is being diagnosed. The criteria A to F must be met. So that means the A is the patient's symptoms, like the nocturnal problems like difficulty in initiating the sleep or maintaining the sleep, or waking up earlier than desired. And then it should causes daytime problems like daytime problems like fatigue, malaise, impaired attention, concentration, memory, mood disturbances, daytime sleepiness, behavioral problems like hyperactivity, impulsivity, or aggressions, etc., and more prone to errors or accidents like that. And this should be reported when an adequate opportunity to sleep is given. It is not because of the lack of opportunity, if there is an enough opportunity to sleep, but he cannot sleep. And it should not be associated with any other explainable diseases. So that is the chronic insomnia, and it has to have happen something like 3 times a week for a 3 month. So then only we call it as a chronic insomnia. And then there is something called a short-term insomnia disorders, which most of us always sometimes do have. Like if you have some a loss of a near or dear one, or a loss of a job, or if you failed for an exam or something like that, you might have some sort of insomnia. That's not a big deal. But if it persists more than 3 months with 3 times a week, then it becomes a concern. And there are some subclassification in ICSD-2 that is called as a psychophysiological insomnia, where when the patient comes to the lab and with the history of insomnia, they say, I slept very well and I didn't sleep likely for the past 10 years or something like that. And that is what is called as psychophysiological insomnia. These people are the one who who get usually a good sleep when they change their environment. And then there is something called as a paradoxical insomnia. Paradoxical insomnia is that when you do a sleep study, you know that the patient is dead asleep from the first nap, first epoch itself, but the next day morning patient will say, "Oh, I didn't blink an eye." So this is something called as a paradoxical insomnia. Such a subclassification of insomnia is not available in the ICSD-3 or ICSD-3 TR, but such wordings are still available for the educational and the research purposes. So the prevalence of insomnia, it is more common in females. Chronic insomnia is something about 10 to 20% based on the studies you are referring to. And then transient insomnia is something like 30 to 35%. It can affect at any age of the any age, but it is more common in older adults. The problem with the insomnia is about the 30% of the insomniacs do have OSA, and the 40% of the OSA patients have insomnia symptoms. It gives a newer term called as a COMISA, comorbid insomnia with a sleep apnea, and this will be a difficult situations to manage. So what are the ICSD-3 TR criteria changes? There is some wording changes, that's all. It is more or less the same thing. There is no big changes in there. So what are the clinical consideration of understanding of insomnia while doing a polysomnography? So there is no need. Polysomnography is not required to diagnose an insomnia. Insomnia is a clinical diagnosis. But then why, when you will do an insomnia, a patient a sleep study, most of the time when the doctors have a suspicion that this patient is having other sleep disorders like sleep apnea or periodic limb movement disorders or any other forms of parasomnias. So that's the only condition where you need to do a polysomnography. Then the most common question used, which we get, is the medication used during the sleep studies. Can I give a hypnotics for these insomniac patients? The answer to that is the why you are doing an insomnia sleep study for an insomnia patient. If it is to find out an obstructive sleep apnea, yes, of course you can give the medication because the patient need to sleep to diagnose the sleep apnea. And the case is the same with the parasomnias or any other form of sleep disorder. So you can use it, but always check with the ordering physician why and can we give these medications. Then there is something called as a perception versus the reality of the sleep, the paradoxical insomnia, which we discussed. Sometimes the patients may say, I didn't sleep at all, and your report is wrong, and sometimes we get such comments from the patients, and sometimes the physicians also get puzzled with such comments. So in that time, you should be able to communicate about the possibility of this paradoxical insomnia with the patient and even with the physicians. And in terms of the COMISA, the problem with the COMISA is that because of the hyperarousals and irritability, the patients to have to use a CPAP may be a difficult task. And so you will be having a failed titration studies with such type of patients. And if at all, if you were able to get a study or if you're giving an auto CPAP titration, the adherence to CPAP also will be very less in such type of patients. So it will be challenging situations. You might have to communicate all your findings and insights with the physicians and then with the patients at the same time. Second one, though the insomnia is the most is a common or prevalent disorders in the community, the sleep-related breathing disorders are the most common type of the sleep disorders which you encounter in a sleep lab. And this is being classified as obstructive sleep apnea, central sleep apnea, sleep-related hypoventilation syndromes, sleep-related hypoxemia, to name a few under this umbrella of sleep-related breathing disorders. If you're looking at the ICSD-3 TR, you can see that almost 20 sleep disorders are classified under the sleep-related breathing disorders. And you can see that it is the only form of the sleep disorders which is being classified as adult and pediatrics. Okay, let's go with the So most of us here in the room, we know that we are very clear how an obstructive sleep apnea looks like, where there is no flow and with continued effort, and then the central apnea, there is no flow without no effort at all, and then mixed apnea, there is a resumption of effort at the end of the flow, at the end of the event. So we don't have any confusion with that, and then obstructive sleep apnea. Obstructive apnea is a one single event, and obstructive sleep apnea is a disorder. So that means you need specific number of obstructive apnea and hypopnea, which is the cutoff point is AHI of 5. So how you diagnose OSA? The A and B or C plus D must be met. What is that? The A means the symptoms, which is the compliance of sleepiness, fatigue, insomnia, or other symptoms leading to impaired sleep-related quality of the life. And then witnessed apnea or the choking, and then bed partner reporting the snoring or the breathing problems. And you do a home sleep study or a polysomnography, which shows 5 or more predominantly obstructive respiratory events, which is obstructive apnea, mixed apneas, hypopneas, RARAS, etc. And or if you have done a PSG without any of these symptoms, but the HI is more than 15, you also call it as an obstructive sleep apnea disorders. And the symptoms may not be better explained by another current sleep disorder. So what are the changes versus ICSD-3 versus ICSD-3 TR criterion? So you can see that in the previous one, in the option A, the 1, 2, 3 was only available in the newest guideline. In the past, there were 4 also. That is the diagnosed with hypertension, mood disorders, cognitive dysfunction, coronary artery disease, stroke, congestive heart failure, etc. That is being deleted, which means that even if there is no, it will be called as obstructive sleep apnea. So we know that OSA is a repetitive episodes of apnea or hypopnea. Prevalence is estimated to be 1 billion people is affected globally by the study conducted by the literature-based analysis conducted by the Benjafil et al. And male to female ratio is 2:1, and this protection for the female is basically due to the hormonal variations. And then after the menopause, it is more or less male and female ratio are more or less, and it is events are even worse during the supine and REM sleep, and mainly seen in N1 and N2. The events will be very less in N3 comparatively, and the duration by the definition, it is a 10-second minimum, but generally 10 to 30 second, and sometimes we may see more than a minute or 2 minutes. So the signs and symptoms is most commonly known, like snoring, excessive daytime sleepiness, tiredness, witnessed apneas, nocturia, sexual dysfunction, gasping, choking, etc. But what is the clinical consideration of understanding of OSA in while doing a polysomnography? There is some term called we know this is more sleep apnea will be worse during supine sleep and REM sleep, but there is something called as a positional sleep apnea, which is sleep apnea getting worse during the supine position, 2 times greater than the non-supine position. But for that to diagnose, you should be allowing the patient to sleep in non-supine position as well. Usually the sleep tech have a tendency to make them sleep in the supine alone and only, but without giving an option for sleeping in the non-supine position, we will not be able to find out the positional sleep apnea component, or we will not be able to comment on it. REM worsening of events and desaturations happens mainly during REM sleep, and hence during the CPAP titrations, we need to titrate a little quickly or than the usual, so that you can achieve an optimal CPAP titration. And the CPAP is the most common device which we need to treat an obstructive sleep apnea 90 to 95% of the time. And the BiPAP may be rarely used in some cases with additional comorbidities. So under the sleep-related breathing disorders, the first one is the obstructive sleep apnea. Next comes the central sleep apnea, and of which one is important one is the chain stroke respirations, which is usually seen in the patients with the atrial fibrillations, the flutter or congestive heart failure, or a neurological disorders. The criteria A or B plus C to E must be must. That means the some presence of the symptoms and the presence of the cardiac or the neurological problem, along with the polysomnography, where the five or more respiratory even it should be in the central in nature. That means central apnea or central hypopneas, and the total percentage of the events more than 50 percentage will be central in nature. And the pattern shows characteristics crescendo decrescendo patterns with a cycle length of more than 40 seconds. So this is very difficult case, even though this is when comparing with the obstructive sleep apnea, central sleep apnea prevalence is very less, and the chain stroke respiration is even less. But once you see a chain stroke respiration, our management and approach should be different. Usually, REM sleep will be free of events. If at all, there will be no chain stroke respiration crescendo decrescendo pattern. Mostly, a fixed CPAP or an ASV is used to treat, in contrast to the obstructive sleep apnea. Here, one thing we should be noticing is that the ejection fraction less than 45 should not be given with an ASV. Generally speaking, auto CPAP is contraindicated. We even see, even nowadays, as the patients coming with the chain stroke respiration on auto CPAP, usually it will not work for the patients. BiPAP, the use of BiPAP is questionable because of the chain stroke respiration usually happens because of the carbon dioxide mechanism, detection mechanism in the fourth ventricle, the central chemoreceptors are not acting the way it should work, and hence when you are giving a BiPAP, there is a possibility of washing out the carbon dioxide to keep the eucapnic level and cause the worsen the chain stroke respiration pattern. Oxygen are also can be added, which will give an additional increase in the carbon dioxide level, which stabilizes the breathing pattern. Then, new addition to the ICSD-3 TR is the treatment emergent central sleep apnea. Here we know once we start CPAP for a patient who has been diagnosed with the clear-cut obstructive sleep apnea, a lot of central sleep apnea is happening. And thus a criteria A to D must be present. And there is an addition of this criteria in ICSD-3 TR that the patient should have the signs and symptoms. Even if there is no signs and symptoms, it will not be diagnosed as a treatment emergent central sleep apnea. Another important disorder is the obesity hypoventilation syndrome, which means that you have your BMI is more than 30, and when you do an ABG during the daytime, PCO2 becomes more than 45. And that's enough. That is called as an obesity hypoventilation disorder, provided if there is no other cause for this hypercapnia. Most of the time, 80 to 90 percentage of the time, the patients with obesity hypoventilation syndrome will have OSA, and hence that is why we need to have the sleep study done for these patients, even though it can be diagnosed by its daytime diagnosis. 10 to 20 percentage of the OHS patient doesn't have OSA, and most of the time the CPAP itself is sufficient because of the concomitant obstructive sleep apnea, but sometimes you may need to have a BiPAP because of if the hypoventilation is severe. The last part of the sleep-related breathing disorder is the sleep-related hypoxemia. When you do a sleep study or a home sleep study where the saturation is below 88 in adult or a 90% in children for more than 5 minutes without much respiratory event, this is otherwise called as a sleep-related hypoxemia. And this can be a sign of hypoventilation, but we will not be able to call it as hypoventilation unless and until we have the carbon dioxide monitoring or a surrogate of the carbon dioxide monitoring, transcutaneous or end-tidal carbon dioxide. If you don't have that, and if you find the SpO2 is more than below 88, more than 5 minutes for without further respiratory events, you can call it as an sleep-related hypoxemia. So, what are the main ICSD changes with the ICSD-3 versus the ICSD-3 TR? As we discussed, the cardiac and the cognitive dysfunction part of the obstructive sleep apnea is being deleted, and the treatment emergent central apnea, they added the patient signs and symptoms should be present. And then there is something called as a congenital central alveolar hypoventilation syndrome, otherwise called as the Ontenkers, where there is a rewording of the mutation of the FOX2B gene. And then sleep-related hypoxemia, then again, there is a rewording. There is no big changes. The main changes happens mainly in the central disorders of hypersomnolence. So insomnia is the most commonest one in general population. Sleep-related breathing disorder is the most common encountered in the sleep lab. Then next we encounter, and most complicated one is the central disorders of hypersomnolence, where you encounter the type of disorders like narcolepsy, idiopathic hypersomnia, Klein-Levin syndromes, etc. And then there is something, a behaviorally induced insufficient sleep syndrome. So what is narcolepsy? We know narcolepsy is a pendard of symptoms where there is excessive daytime sleepiness, which is characterized by the Epworth sleepiness, higher the score, and then cataplexy, which is the muscle weakness provoked by strong emotions like laughter, joke, or happiness, whatever, and to some extent by the anger. Sleep paralysis, inability to move your body, just waking up or just before going to sleep. It is a very scary situations. And then you might have an hypnagogic hallucination, seeing or hearing or feeling things which are not present. And then the fifth one is the disturbed nocturnal sleep. These patients with the narcolepsy do have all these five symptoms, five pentards, and other symptoms include automatic behaviors. It's almost 20 to 40% of the people experiences automatic, subconscious, unconsciously they perform the activities, often appearing deliberate. Not all patients do have all these symptoms, but most of them have more than one. So the question is, what is cataplexy? The cataplexy is the muscle weakness while doing, let me, so you can view this video. This fisherman is fishing and he got a fish, and the happiness of that is going to make him lose his muscle tone, and you can see his eyelids is closing, then facial twitching, and then neck slowed down, head is going down, and he falls down. So this is a classic example of a cataplexy. It is otherwise called as a typical cataplexy, where he is bilateral muscle weakness and falling down to the ground, and within few seconds he gets up. You can see this video. It is available in the from the YouTube. All right, so I don't know, it's not knowing. So what is happening in the sleep paralysis and hallucination? Sleep paralysis occurs in 25% of the patients. It may be happening at the sleep onset, or hypnagogic or hypnopompic at the time of awakening. So what is the diagnostic criteria changes in ICSD-3 TR versus ICSD-3? Here, there is a criteria A to C must be met, which is the patient has a daily periods of irrepressible need to sleep or a daytime lapses into drowsiness or sleep, and the presence of one or both of the following. What is the cataplexy? and then CSF hypocretin. So the cataplexy is defined as essential feature and either a mean sleep latency of less than 8 minutes and 2 or more sleep onset time period on a multiple sleep latency testings, and either, so here is the catch, either and a SORM within the 15 minutes of sleep onset on nocturnal polysomnograms, which means that if you have a cataplexy, which is a characteristic of type 1 narcolepsy, and if you do have nocturnal polysomnogram SORMs, that itself is sufficient even without doing an MSLT. That is the newest changes here, along with for the narcolepsy type 1. The second thing is that the CSF hypocretin level is less than 110 picogram milliliter, and these symptoms are not better explained by any other chronic insufficient sleep or a circadian rhythm sleep wake disorders or other current sleep disorders, which is very important, which we will discuss later. And then in the narcolepsy type 2, there is no big changes, similar to the earlier one. Same thing, it is you have to have a nocturnal PSG and you need to have a MSLT next day, and the mean sleep latency less than 8 minutes. There is no, and 2 or more SORMs, but there is no cataplexy symptoms. In this case, CSF hypocretin will be greater than 110 picogram, and in the previous one, it is less than 110. So technically speaking, hypocretin is the cataplexy initiating factor. So then idiopathic hypersomnia is happening when there is no signs of signs of narcolepsy, there is no SORMs, but the mean sleep latency is less than 8 minutes, then there is no other sleep disorders. So basically, what is the changes between the ICSD-3 versus ICSD-3 TR includes the presence of cataplexy and the presence of SORM will be sufficient to diagnose the narcolepsy. That is the main thing. Idiopathic hypersomnia, there is a rewording of that one. And then there is something called as an insufficient sleep syndrome. You can see its name is called as a behaviorally induced insufficient sleep syndrome, even though it is a induced sleep problem. It is been classified under central disorders of hypersomnolence for one reason, because if you didn't get this one, you may end up diagnosing narcolepsy 1 or 2 or idiopathic hypersomnia, and they will be on medication forever. So insufficient sleep syndrome must be tackled first in all the hypersomnia patients. And so what are the clinical consideration? If you are dealing with the central disorders of hypersomnolence patients, the preparation should start at least 2 weeks prior to the test. Sleep diary should be kept, actigraphy must be kept, medications affecting the REM sleep should be stopped, or like antidepressant and stimulant should be stopped at least 2 weeks before, and then urine screening may be also added. The next group of disorders is the circadian rhythm sleep-wake disorders. It is the most common one we remember is the shift worker disorders, jet lag, delayed sleep phase, advanced sleep phase, etc. So what is the main point here is that our circadian rhythm of regular sleep is being disturbed because of the external factors. Usually, the delayed sleep phase is seen in teens and all the people's adults, like where the patients usually go to the bed around 2 to 4 a.m. and then wake up very late in the morning. But in the advanced sleep disorders, it is usually seen in the older people where they go to the bed 7 to 9 p.m. and then wake up very early in the morning and making all the fuzzles in the home. So it gives both cases gives a social problem. They cannot attend the school or the college or whatever, and or social functions because of the these sleep wake disturbances. Of which one of them important is the shift worker disorders. because when we work in the healthcare field, we are supposed to work a shift worker, and we do have symptoms of insomnia, in difficulty in initiating, or excessive sleepiness. It can have any of these one, which causes the impaired work performance and reduced productivity, increased risk of accidents and mistakes at work, etc. And they are at a likelihood of developing psychological, physiological health problems such as depression, cardiovascular diseases, and other metabolic syndromes. So always we need to have a work schedule that it allows us to have a pattern of regular sleep cycles. And there is no big changes in the circadian rhythm wake disorders in the ICSD-3 versus ICSD-3 TR. There is some rewording or rephrasing of the content. What are the clinical considerations of understanding of the circadian rhythm disorders? Adjusting the appointment time to meet the patient's sleep timing is required. For example, the patient is sleeping very late. For those who is having a delayed sleep phase syndrome, scheduling a patient from 7 to 6 a.m. may not be possible, or it won't work for them because their sleep time is from 5 to 10 or 12 p.m. So this is a challenging situation, and we might have to see how it can be compromised, and then how we can get it done. And then, even though dementia patients, it is not a part of the circadian rhythm, we do have a problem with these patients when they comes with the problem of sundowning. When they come to the clinic to see the doctor, they are there is no big problem, but once the sun goes down, their problem, irritability and being aggressive and being a different person. So they might start removing all the wires. If possible, it's better to get a home sleep study for those patients rather than a PSG. Sometimes it is beyond our control. The last one is the fifth one is the parasomnias. We have several abnormal movement or behaviors like walking, talking, eating, something like that. So there are several classifications of the parasomnias, which is again classified into NREM related parasomnias and REM related parasomnias. Most of the confusional arousals, sleepwalking, sleep terror, which is screaming and wake up from the sleep. It is a terrifying scene, actually, the sleep terror. If you encounter, you will remember for lifelong. And then sleep-related breathing disorders. You are sleepy, you walk out, and then you eat, and which you are unaware of the situations. There are several other disorders also, like it is a medico-legal cases as well, where there is a sexomnia and then or sleep-related homicides. So sometimes it becomes a medico-related cases as well. And we will be having further discussion on the parasomnias while discussing the chronobiology or neurobiology of the sleep in November in this webinar series as well. So in short, we can say that we have NREM-related parasomnias and REM-related parasomnias. REM-related parasomnia like a nightmare or a REM behavior disorder, which we will see a video down. Usually, NREM related parasomnias like walking, talking, eating, all those stuff happens the first half of the night, because usually it is considered the deep sleep entry associated. And those REM parasomnias like RBD, nightmare, and sleep paralysis, etc., can happen towards the second half of the night. So what is the you can see a video. This is the RBD patient showing being violent. He is having a dream, maybe fighting with the gangsters in the road while trying to rob him or his wife or somebody, and he is fighting with them. So what is the So this is the epoch of a REM sleep, and you can see that the chin EMG is very low or a pepper thin, and this is what is happening where the chin EMG is very high in this patient. So, what is the new guidelines with the would do changes with the ICSD-3 TR with the parasomnia is in terms of the sleep enuresis, it is being changed to the new term called as a sleep-related urologic dysfunctions. And then under the sleep-related urologic dysfunctions, they have two disorders mentioned. One is the nocturia and then nocturnal urinary urge or incontinence. So nocturia, we know it's urination followed by sleep or at the intention of the sleep. This condition has been present for at least 3 months, and it has to be or patient is older than 5 or more. And in the urge or incontinence is that patient cannot hold the moment he wake up, he just pass the urine. So this is what is. So they have divided, renamed the term sleep aneurosis into sleep-related urologic dysfunctions and been then classified two type of disorders under which. So what are the clinical significance of understanding the sleep-related parasomnias? Sleep terror, if you are seeing a sleep terror, avoid waking the patient. Safety first, you watch the patient. If there is any unharmful situation, minimal interaction, don't interfere, wait it out. It will settle down and patient will go back to sleep. And next day morning, if you ask them what happened, he even doesn't recall the event. If you are seeing an RBD patient, physical safety in the sleep environment, you have seen that video, the patient may fall down. So you need to take care of that part, and the patient safety is important. You should remove any obstacles or any things which is sharp, and padding of the area is also required. If it is a nightmare, on the other hand, of the sleep terror is something happening in the NREM sleep, but if it is nightmare, which is usually seen in the post-traumatic stress disorders patients, you reliving the moment of those difficult situations. Patient will scream and shout and wake up. You can go to the patient and talk to them because it is unlike the sleep terror. You will not be the cause. You can advise some relaxation technique. If the urologic dysfunctions, parasomnias, you know what to do. You need to pad the bed or use Pampers. Otherwise, all your electrodes and sensors will be wet in urine. So um, another second last one is the sleep related movement disorders. We know there are several classifications for this one. Is this restless leg syndrome, periodic limb movement disorders, sleep related leg cramps, sleep related bruxism. All these type of movement disorders are classified under the sleep-related movement disorders, and you can see that this is an example of a sleep restless leg syndrome patient. You can see the background EEG is awake, and look at the leg. So he started moving it. So it is there is an unpleasant, undue sensation in the leg, which making the patient to move the legs throughout the night. Sometimes, usually, it happens in the first part of the night. It is, even though it is happening during the wake time, it is considered to be a sleep disorders because it prevents the patient from going into the sleep, and sometimes it may continue in the sleep as a periodic limb movement disorders. So here, this is the periodic limb movement. You can see the leg. The patient start moving the legs. Here, see, this is the leg movement. This is one leg movement, and periodically, something between 40 to 60 seconds, he start moving it again, and it disturb the sleep and its quality, making the patients to feel sleepy during the daytime. This is the second time it's happening again, so it happens. It continues down the road. So this is how a sleep periodic limb movement occurs during the sleep study. You can see it here. Then the difference between RLS and PLM. RLS happens before the sleep and periodic leg movement happens during the sleep. This is a bruxism patient. You can see some of the other movement disorders which usually associated during the mainly in the pediatric cases. You can see this is head banging. See, the patient is still awake, and it is some sort of movement. You can see this is the rhythmic movement disorders. You can see that, and it is making them to not to have the sleep. And you can see here the patient background EEG is showing sleep, delta sleep. You can say, you would say, this is basically body rocking movements. So, what is the considerations of understanding of the sleep-related movement disorders? If you have sleep-related movement disorders, you always need to document, video it, so that you might need to change the blankets out of the leg area so that we can clinically view the body movement or the muscle twitches, etc. So then the last part is the other sleep disorders, which is most commonly seen as, which is mainly the sleep-related epilepsies, fetal familial insomnia, sleep-related MI, etc. Here, um, so you can see one of the uh, epoch here. This is most of the time you may feel this is a normal looking N2 sleep with some K complexes here. But if you really look into that, you can see that this area is something abnormal. So this patient is been referred to the sleep lab for the sleep disorders, insomnia, and difficulty of excessive daytime sleepiness. But when we do this is the pattern which we notice throughout the night, especially in the NREM sleep. And when you zoom in, you can see that the spike and slow wave followed by us. And we discussed with the doctor, and then we had to send them this patient for the neurological evaluation and found to be having the seizure disorder. This is something called as interictal discharges, and it is difficult to see in a limited channel montage, but still you will be able to see that. So seizure disorders is also a part of the other type of the sleep disorders which you may encounter in the sleep lab, and you may need to be equipped for that as well. You can see in another epoch here, you can see that the ECG changes which is happening like uh, trigeminy or tetrageminy or a pentageminy, something like that, and it is happening throughout the sleep stages, and it is also needs to be reported accordingly. And here you can see that there is a sinus exit pause, which is something associated with the obstructive sleep apnea, and this is something serious and has to be reported. So all these disorders which we have discussed all the 7 sleep disorders where we have covered insomnia, sleep-related breathing disorders, circadian central disorders of hypersomnolence, circadian rhythm disorders, parasomnias, movement-related disorders, and other sleep disorders, and what are its clinical significance as while doing a polysomnography, and what are the new changes with the guidelines. So thank you for watching, and please scan for the this QR code for getting your CME. It is CME will be provided through the HAD. You have to submit, you have to do the evaluation form, and then you have to do the TAM applications. Thank you.